everyone, this is Dr. Mitesh Gala, MD Medicine, practicing in Khar West and Lower Parel with multiple hospital attachments. I think the topic for today's discussion is ARB usage in COVID-19. I think this has been a broad spectra topic for discussion. At the initial level, when we had started this discussion, people were of the view that ARBs or people taking ACE inhibitors usually resulted in worsening of the COVID-19 infection. But that was a very small study size that had happened then. But now with progressing studies, it has been clearly demonstrated that use of ARBs should not be discouraged or neither should be discontinued in an actively going SARS-CoV-2 infection. So to all the clinicians and physicians, ARV should be prescribed irrespective of the disease at length. So I'll just brief you a little about the pathophysiology of how ACE inhibitors work. Yes, so angiotensin 1 enzyme is broken down to angiotensin 2 by the ACE enzyme, that is the angiotensin converting enzyme. This angiotensin 2 binds to the ACE2 receptors. These ACE2 receptors are predominantly present in the lungs, heart, endothelium, and the kidneys. Whenever angiotensin 2 binds to these ACE2 receptors, it gets converted into its degraded products from angiotensin 1 to 7 in varying proportions, terminating the use of angiotensin 2. So that is why a lot of studies that were published earlier on, a small study was published in China at the start, demonstrating in overexpression of ACE2 receptors, resulting in progression of the SARS-CoV-2 infection in people taking ACE inhibitors or ARBs. But then subsequently, a lot of studies have come in, published by the JAMA Network, published by the European Society of Cardiology, American Society of Cardiology. So now they are of the view that discontinuing ACE inhibitors or ARBs might do more harm. So these belong to a class of drugs which are called as RAS inhibitors. RAS inhibitors includes three categories of drugs, namely ACE inhibitors, angiotensin receptor blockers, and angiotensin neprilysin receptor blockers. So people taking or patients taking either of the three classes of drugs should not be changed irrespective of the disease status, and if required can also be put on those therapies in the current scenario. So now I'll just brief you a little about how at the micromolecular level these things work. Earlier it was said whenever a patient is being given ACE inhibitor or a ARB group of drug, the angiotensin 2 formation is blocked, resulting in up titration of the ACE2 receptors at the membranal surface, resulting in increased binding of the SARS-CoV-2 infection to these receptors, resulting in propagation of the infection. But this is no longer agreed now. So now, according to the clinical current scenario, abrupt discontinuation of therapy puts them at risk of complications and exacerbations of the disease. In patients with hypertension, discontinuation or switching of a drug can lead to rebound hypertension and transient suboptimal control with the new agent, thus predisposing the patient to intermittent high BP fluctuations, which can augment the risk of developing cardiovascular events. Especially seen in heart failure patients, sudden discontinuation of ACE inhibitors or ARBs has been shown to have a deteriorating clinical status with a possible relative increase in mortality. Especially in post-myocardial infarction recovered patients, in left ventricular dysfunction patients, the use of ACE inhibitors and ARBs should not be discontinued. There is a lot of data which is also showing potential beneficial effect of ACE2 receptor as a very potential anti-inflammatory agent. That is why now a lot of studies are saying to use recombinant ACE2 as a potential treatment option in patients who had moderate to severe cases of COVID-19. This sudden abrupt discontinuation of these agents in patients already taking this can also result in a lot of cardiovascular worsening and can also precipitate ARDS or acute respiratory distress syndrome in patients due to suddenly increased levels of angiotensin II due to discontinuation of these agents, thereby again propagating the RAS axis, thereby initiating or potentiating lung damage. So now the broad consensus regarding use of ACE inhibitors or ARBs in COVID-19 is they should be used, they can be initiated safely without thinking about the possible outcomes of SARS-CoV-2 infection in the current scenario. This topic is of profound significance as the most commonly studied comorbidities in patients who have been hospitalized with moderate to severe SARS-CoV-2 infection is hypertension. So hypertension contributes amongst the most common comorbidities in patients who are currently suffering from an active infection, be it a hospitalized patients or be it ICU, be it patients in ICU. That is why now, just briefly summarizing the entire thing, ACE2 inhibitors have potential anti-inflammatory effects in preventing the infection and preventing its potentiation as well. ACE2 inhibitors should not be discontinued and can be safely initiated in the current scenario. Sudden discontinuation can lead to disruption or worsening of the cardiovascular events and can even result in acute lung injury or complications of the lung illnesses or worsening or potentiation of an active COVID infection. Thank you.